and so wonderful to see the authors, and wonderful to have our participants joining this webinar. And let me just add to the words that have already been kind of shared here, that the efforts of the authors to this volume, in 2020, at this time that we all know was so difficult for all of us in many ways, including the people that we work with in the field, just is testament to the brilliance of the anthropological scholarship here. So thank you from me too. Now, the third part of the book we've titled Unequal Burdens, and I don't think it's any surprise to anyone, also given the discussions we've just had on the first two sections, that kind of disproportionality is one of the themes that is perhaps the most striking. And indeed, in our introduction together with Lenore and Nancy, we tried to kind of think about that in terms of stratified livability. So let's move straight into the third section, and we have a number of our contributors with us today. So I would like to start with Linda and her team, who wrote on sexual and reproductive health provision of healthcare in Indonesia. So could you tell us a little bit about how the pandemic affected those efforts that you had been working on for so many years?
Yeah, thanks very much, Ayo, and nice to cite you in this transnational world. And also my co-author for this paper is not with us because she's busy reproducing. She's in her first trimester and cannot get out of bed. So I just thought that's an interesting link. Look, I think that what we found was really interesting was the way that people who were already marginalised, things just became so desperately difficult for them so quickly. I hadn't intended to do this research, but there was a call from the communities that I've worked with before to get involved. And the first thing that happened, of course, all over the world is that livelihoods were lost. And in particular, we were working with trans women, MSM, men who identify as queer or gay. Their livelihoods are in the informal sector, and they're often in the intimate industries. And when you can't touch anymore and venues aren't open, even if you're a wedding planner or a salon stylist or a masseur, all of those opportunities to earn income just disappeared. So more people were turned towards sex work, and more people were turned towards unsafe sex work. And when I say unsafe, I mean unsafe in the terms of sexually unsafe, but it was also physically a lot more unsafe. And there was a horrendous spate of murders against transgender women at the beginning of the COVID-19 pandemic in Jakarta. For some reason, their kind of physical appearance in public spaces was increased by the lockdown because they didn't have anywhere else to work or pick up clients. And, that was met with backlash, violence and antagonism. So the first thing that community was reeling from, and the first calls for help that we got, were document the violence against us. Then it was assist with the financial side of this. And the financial side was even harder because a lot of the people in these communities don't have legal identities. They don't have legal identities because they don't match the gender on their birth certificate, or they don't have legal identities because they're discriminated. And when they go to offices to gain the identities, they're turned away. So we have no incomes, increased violence, and also then the services that these marginalised groups access and depend on were identified as non-essential health services. So all outreach services, free condom services, free VCT, all kinds of services that go out into marginalised communities and offer care were cancelled. The budgets were just removed, and the rationale behind that was it's dangerous to go into those communities, so therefore we'll reallocate the budget to the COVID-19 response. So they weren't safe in terms of safety as a human being. There weren't safe services for those communities anymore, neither were their livelihoods. The other thing that they were suffering from was also the inability to go home, because as COVID broke in the sort of mega cities of Indonesia, many people went home to the regions. So, it's a country where there's 50% of people are living in huge cities and 50% of people are living regionally or rurally. And for many of the transgender community or MSN community, they couldn't go home because the reasons they left home were because they were non-normative. So, they didn't have the same social capital to draw on or any economic capital from the government. There was an enormous amount of advocacy And that advocacy did end in the government changing the essential medicines catalogue, which was fantastic. So ARV was readily available for people who are HIV positive. And obviously not all queer people and not all trans women are HIV positive, but that was a huge concern in that community. And they successfully lobbied for that change. They also lobbied to get, financial assistance, which was stronger in the beginning of the pandemic and is now, sort of run out because there's no more assistance left. Everyone in the country is sort of, well, not everyone, but, food security's gone up by 30%. So the people who were helping out are now in a position where they can't help out. And I suppose the other thing that I wanted to sort of touch on was also the resilience that occurred in these spaces. And the people that we found were experiencing the highest degree of resilience were those who managed to get a legal identity. There's a huge difference between people who are managed to get a legal identity. So people who are under 18 couldn't get a legal identity, people whose gender didn't match, their gender appearance didn't match what was on their birth certificate couldn't get a legal identity. People who were linked with CBOs were experiencing less homelessness and less food insecurity. And those who weren't linked were experiencing, more food insecurity and higher levels of violence. So there was a lot of...
We'll have to start closing.
Yeah, okay, sorry.
Well, thank you, Linda, and joining us from Melbourne, so we know another late attendance here, so much appreciated. And absolutely your kind of framing in terms of the amplification effect and this exacerbation of these already existing disadvantages, I think will resonate across a lot of the chapters and contributions. So Surekha Garimella in Delhi, India, and Sabina Rashid in Dhaka, Bangladesh, both of you lead major research projects on very exceptionally poor and marginalized populations. And I would like each of you to in turn to discuss their immiseration with COVID restrictions. So 2020 was really a year of lockdown, as we know. So Surekha, first, your chapter on waste pickers or collectors of Delhi. Tell us about your work and their experience.
Thanks, Ayo, and everyone. So just to get straight, because I just have 4 minutes. So I think just from what Linda was saying, that communities that have been discriminated historically, and then waste picking communities in India have literally decades, even before colonization, where people from particular castes ended up picking up waste and cleaning even human waste for the upper castes. And that actually got solidified during the colonization that occurred when the British colonized us. Unfortunately, post-colonization, it is still the same. So they are waste-picking communities across the country, and in a lot of urban spaces are extremely marginalized groups. So what is it about COVID-19? Like we have written in the chapter that we don't think COVID-19 is an event for them, because this is a slow wearing down of these populations. And exclusions happen in many different ways. They were already excluded in the research space, in the policy space, in the social security space, and even in terms of access to streets in the cities where they can pick waste. So the exclusions happen at the social level, at the family level, at the state level, and so on. So I think those remain, they have not gone away. But I think for the team, the TGI team, where we are working with the thing, I think the one of the most distressing aspects of our work has been the loss of dignity that these communities have experienced and keep sharing with us, because they did get by before COVID-19. They managed to keep the hunger at the door. But I think we are into 2021 September, and our team is still doing relief work in terms of getting food rations to them to keep the hunger at the door. So they are back at work now. There is no lockdown. But as you know, that the fallout of the pandemic has also affected the markets for recyclables. So what it means is that these are communities that get up at 3 in the morning, start walking at 4, walk till 1 in the afternoon, go home, take a bit of rest, and then spend another 3 hours carting the recyclables to go and sell them. Now, the same amount of time and energy is being spent, but they're getting lesser money. The other fallout has been school closures. Some of them managed to get their children into residential schools run by civil society organizations, which closed down. So there are more mouths to feed. So I think it's not just about what it has done, but it is this sort of layered kind of thing. And I think one of the mistakes that's been happening in terms of dealing with the pandemic is, for example, there is extremely differential access to vaccines. And the poorer communities.
We'll have to slowly wrap up.
Yes. And I think one of the things is that the burdens that have come are also very gendered. And what we're seeing is that the women in the community are doing all the care work. So I will stop here and take questions later.
Thank you, Surekha. And I think this point that, you know, there are groups for whom COVID was one more trouble in you know, amongst a host of troubles, if you could put it like that. Could we move on to Sabina in Dhaka? You have worked with young people unemployed, often without families. Could you tell us a little about your research?
Sure. I wonder if it could go into Windows, just the slide. I think it's still in, but I'm not going to complain. Thank you so much. I'd really like to acknowledge all the editorial team for making this chapter much better than what we'd started with. So thank you for that. I'd like to thank Salima, Kim, Sally, Batra, and Aisha, who are co-authors. This is funded by the Arise Project. So very quickly, when it happened last year, the country was in shock. It was announced as a global pandemic by WHO. Unfortunately, during that time, it was a very clinician-led approach. And there was a national shutdown for about 3 to 4 months. And national shutdown meant shops, schools, restaurants, transport, education, everything was shut. And they had a very sort of clinician-led approach. Wear masks, wash your hands, keep distance. This is a picture of one of the largest slums. To keep distance, to afford to buy masks, and to wash your hands, where you have communal latrines, where you have communal bathing spaces, is very difficult. About 87% of the workforce were extremely affected. Factories had been shut, retail shops, street peddlers couldn't apply on the streets anymore. There was the army on the streets and the police. The chapter focuses on adolescents. One, they're a heterogeneous group, and they're much more vulnerable because in some ways they're invisible, but they're also there in terms of let's focus on child marriage or let's focus on certain aspects. But this is a group that has navigated themselves in a very adult world. So in these spaces where there was an economic shutdown, where there's no income, you have to navigate with your landlord, your storekeeper to buy food, to get credit. And they're also navigating any kind of jobs in spaces with adults is extremely difficult. So what they did was they're resilient, of course, and they tried to remake and unmake their social spaces in the best ways possible. Some of the challenges were that if you're under 18, you don't get a national ID card, which means you couldn't be officially part of the relief material list. Many who lost their jobs started taking loans. They started selling fruit, hiding from police, running away, being beaten. One young woman who just had a baby walked to 30 houses by foot, desperately looking for a job. She was turned away because the poor are already, as the other speaker said, already excluded. They were seen as contagious and spreading the disease. And there was also many who had actually graduated to garment work who went back to street peddling, which is going on the streets, trying to stop cars to get money. So the reality is when you look at concepts of risk in public health, we really have to unpack what does health mean economically, socially, politically. Also, my final points are, what does risk mean? Degrees of vulnerability. And here's a group that, you know, we need a contextualized understanding of their lives because many of them are young. They're in many ways even more marginal than other groups. And they've had many dreams, many aspirations, but they're lost. In a way, they've stolen childhoods as they try and live out these worlds in the new pandemic situation. It's not that they were much better off before, but they were better off. They were making ends meet, they were managing, but they were completely restricted by the shutdown. And it was a cycle of uncertainty and emotional angst. Thank you very much.
Thank you. So yet another example of this disproportionality that this section really highlights. So moving on to Tsipy Ivry, who joins us from Israel. So another minority of a kind are people whose religious practices set them apart from others in the community. And women are a particular minority in this context. Could you tell us a little bit about the kind of tensions of faith and care that emerged with the COVID-related infection control among the Orthodox communities in Israel?
Thank you so much, Ayo, and thank you, Lenore and Nancy, and thank you everybody for this fascinating, really fascinating project. So actually, our observations of the tensions between Orthodox communities and infection care indicate that a crisis can actually become an opportunity for reform. And so during the first outbreak, Jewish Orthodox centers were registering the highest infection rates in Israel. I mean, as you can see from the graph, Orthodox communities often comprise of large families, and when living in urban areas, this means overcrowded housing conditions. And when infection rates started rising, they were accused of endangering public health. Stereotypes of religious communities as resistant to state and public health rationales were invoked. This was in spite of the fact that in many communities, the rabbis were engaged in restructuring long-standing religious styles of worship and sociality. And so there was much innovative negotiations of religious law, of halacha around, but marital sexuality became the locus of particular tension, and the tension actually evolved around this, which looks like a little swimming pool, but it's not. It's a ritual bath. It's a women's mikveh. An ancient halachic requirement is that women immerse in a mikveh after menstruation as a condition to resuming sexual relations. So before a woman immerses in a mikveh, the couple cannot even touch. In Israel, mikvehs are public bathhouses operated as state services. So as you can imagine, immersing in a public mikveh means having to go down the steps to the immersion pit, holding on to the railing that other women touched already, and then dipping one's naked body in the waters in which other women have also dipped. So here we are, we have the paradox of a purification ritual that becomes potentially infectious. Swimming pools were closed down, but women's mikvahs remained open throughout. State-authorized chief rabbis assured the public that women's mikvahs were safe, but there were cases of women who tested positive soon after visiting the mikveh. And halachic alternatives to immersion in a public mikveh were being published in social media. So the debate really intensified when two women rabbinic scholars, Sarah Segal-Katz, who co-authored with the chapter with me, and Dr. Chana Adler-Zarovich, a gynecologist by profession, published an evidence-based halachic statement describing how difficult it is to know what is the state of sanitation in the mikvehs. They pleaded the state for clarity, for transparency, and for supervision. And they showed that for decades, supervision was compromised, actually, in the name of cultural sensitivity. Ministry of Health officials confessed the lack of resources needed for adequate supervision, but refused to close the mikvehs, claiming that the religious requirement to immerse is non-negotiable, and what will the religious communities do if the mikvehs are closed? But the women scholars encouraged women to consider not immersing if they were unsure about hygienic standards, and claimed that there were halachically appropriate ways to uphold abstinence. if the risk of infection was to linger. Their statement led to a heated public debate, and actually they succeeded in pushing the issue of sanitation in mikvaot to the forefront of discussion, and also they increased the visibility of women's halachic authority in public. And just a final, the point—
Very quickly.
Yes, very quickly. The point is that religious obligations are negotiable, and that public health policymakers should never forget that.
Thank you so much. So here we had very different but also resonating examples of these different ways in which this disproportionate distribution of these burdens really have played out across the world. So I'm just going to hand over to Robyn Eversole, who will take us through the question and answer for this section.
Thanks so much, Ayo, and thank you for the panelists for a fantastic session. Apologies, the timing is such that we have the clock striking midnight in Tasmania. Just looking through the questions, we have a couple that came in during the panel from Bangladesh. One from Sadika Haike, who asks, the divorce rate has increased during COVID in Bangladesh, and she'd like to know, is that happening in other parts of the world? And if anyone, particularly on this panel, has had any observations around the domestic violence issue. And again, feel free to just jump in, panelists, with your comments.
Yes, maybe I'll just quickly say that domestic violence was one of the issues that were discussed in the Orthodox public when the mikveh, the state of sanitation in the mikvaot was starting to arise. Actually, there was a huge anxiety. What's going to happen if we abstinate? So
I just wanted to add to that comment, Sabina here. We found in our RISE project study, we're following a group of communities in 3 slums, that there's a lot more tension, arguments, abuse and violence, yes, emotional distress, men venting, women really upset. Other studies like BRAC, the NGO, found sort of high levels of violence occurring in households, yes.
Thanks for that. No, it's a really important issue. Yes, Linda?
So the same has been documented by the Commission for Violence Against Women in Indonesia, about a 3-fold increase in reports, and also a big increase in first-time reporters, so people who hadn't ever reported any kind of domestic violence prior to the pandemic, and also a higher degree of younger people. Children and also young people in relationships. So the age skew seems to be towards younger people. And in Australia, in Melbourne, we've had a 3-fold increase in domestic violence reports. And our stats are pretty good. You can actually rely on them.
Yes, in Mexico, we have also seen a huge increase in domestic violence rates. And at one point, there were more women dying for domestic violence than from COVID-19. So that is something that also the government discussed in their daily briefings. And yes, we have seen an increase on that rate. Thank you.
Thanks, April. And thanks, Sadika, for that question. That's obviously a really important issue, and one that has a lot of resonance across national. From Bangladesh, from Bachera, who asks Linda, what is the response of the government in Indonesia to support the poor people? And Bachera observes that in the Bangladesh context, the people that are living in informal urban settlements are left out from COVID-19 response plans.
Sorry, I did answer that in more depth directly, and thank you for the question. But basically, they haven't been left out. If they don't have a legal identity, it has made it difficult to access, but there's been a huge push to try and help. But the amount is $60 a month per 4 people, which is enough to have 1 meal a day. It isn't enough to prevent stunting. It's not enough to prevent hunger, and it's not enough to prevent malnutrition. But it's still going on. you know, after all this time. And, you know, the size of the country, 270 million people, it's a fairly large commitment. So also, you know, you can get together with a group of 4 and you can hope that one person in that group of 4 might have ID. So there's been a lot of sharing as well, a lot of sharing, a lot of creativity in communities to try and access that help, and some really big drives to get people's formal identities recognised. Not enough, but it's something.
Thanks, Linda. We have a question from Tom from Belfast in Ireland, thanking us for an engaging roundtable, and just raising a really interesting question of the elderly in care homes and the social isolation, and asking if there've been any accommodation for the social needs of the elderly as opposed to just their biomedical needs. Would anyone in the panel like to jump in for that? I think it's a really important issue.
Judy Friedenberg here. I am saying that the elderly were also stigmatized originally by isolating them in care homes, but in general, you know, once you know, there were public health statements that the elderly were more vulnerable to the COVID risks, and they should refrain from being in public, including the vaccination for the elderly first, which was a good measure, but you know, the elderly were sort of isolated and invisibilized during the pandemic.
Yeah, thanks for that, Judy. Thanks for jumping in. Look, I think there's some really good reflections on the chat, particularly about domestic violence in different contexts. And I'm going to carry away from this evening one observation in the chat: if only we could vaccinate against violence. And on that note, I'll hand it back to Lenore for the next session.
Thank you very much.